Good afternoon, everybody. My name is Judith Currier. I'm from the University of California, Los Angeles, and I'm pleased to be here with Dr. Kara Chu, who I will let introduce herself in a minute. We are here today to talk about early treatment for COVID-19, meaning outpatient treatment. And a few just housekeeping things before we get started. Today, the chat function on Zoom is disabled, but you are able to put your questions in using the Q&A button. Dr. Chu and I are going to talk back and forth, have a conversation about this topic for about 40 minutes, and then we will open up for the questions. The dialogue that we're having today is not available for CME, but it will be available as a web or podcast after the event. So just making sure that folks know that. But we're really looking forward to sharing some information and talking about this important topic of early treatment for COVID. So I mentioned I'm at the University of California, Los Angeles, where I'm an infectious disease clinician and a professor of medicine and chief of the Division of Infectious Diseases. I'm also the chair of the AIDS Clinical Trials Group. And in the last year, I've been involved in COVID outpatient therapy through the NIH Foundation's Active Partnership and a study called Active-2 that we'll talk more about. But one of the leaders of the Active-2 trial and protocol co-chair is Dr. Kara Chu. Kara, do you want to introduce yourself?
Yeah, thanks, Judy. So like Judy, I'm at UCLA, also an infectious disease physician. I'm an associate professor. For the last year or more, I've been working every day, 24 hours a day with a great team on the Active-2 trial, trying to find effective and safe outpatient therapeutics for COVID. Previously, prior to COVID, was an HIV and HCV Hep C clinician and researcher, and now, probably like many of you, a COVID clinician and researcher.
So, I mean, I think it kind of goes without saying too much, but Kara, maybe just start off with a little bit about your thoughts about why it's important to have outpatient treatment for early treatment for COVID.
Yeah, so I mean, I think we're all aware of the massive global impact of COVID. Over 136 million cases now worldwide, almost 3 million deaths reported. And so even with vaccines being rolled out, we know the pandemic is ongoing, and there are many that are suffering from serious complications and still a need for effective therapeutics. And we've made a little bit of progress, but we really still need more scalable therapies, which we'll talk about today. And I think, we need treatments not just for those to prevent those serious complications like hospitalizations and deaths, but also the long-term sequelae that we're observing in some people who most of whom are not hospitalized actually, and then further need a treatment to prevent transmission and help curb this pandemic.
Yeah, I think those are really the key points. And, if you think back over this past year, we really have not had any easy to give effective early treatment. And the consequences of that have been enormous. I think it's been, if we had something that could prevent transmission within households and prevent hospitalization, this pandemic could have turned out to be very different than it has been. And I think even, despite the fact that vaccines are rolling out, we will always have people who are unvaccinated or can't respond to vaccines that we need treatment for. So these efforts are needed and need to continue. But it's been challenging to study outpatient COVID, and you've been very involved in setting up a site to do so. Do you want to just talk a little bit about what some of these challenges have been and how they've been overcome?
Mm-hmm. So this is a new disease, and with new concerns for transmission risk. So I think one of the biggest challenges with setting up treatment sites and study sites has been literally the logistics of that. So, right, like finding the space at our medical centers, or even if we wanted to try to branch that out to community-based centers, finding the space, creating the space to safely see people who are COVID positive, considering the infection prevention requirements. There are also logistics around finding and licensing a space for administering investigational therapies. So I think very new circumstances for us to rapidly respond to.
Yeah, and I think the other issue has been just that the disease is, obviously it's a new disease, but it's a disease of incredible extremes where, the majority of people don't get sick. But when somebody is diagnosed, we don't know if they're going to be the one who's going to get sick and need to be hospitalized, or if they're going to be just fine. And then we also, as you mentioned before, don't know what the long-term consequences of the infection are going to be. So developing and designing studies and figuring out who we should treat has also been a big challenge. And we're definitely learning more about that. But when you have a new disease like this, I think it's essential that rigorous studies be done to evaluate therapeutics. And that means, in the absence of any effective therapy, having a placebo group until such time that we have treatments that work. And because we don't know how, in observational studies, we don't know what factors to control for. And we know that a lot of people are going to get better without doing anything. So I think that's been a real challenge in the whole field, is the lack of really rigorously designed controlled studies that have good ascertainment of the diagnosis. And that was hard in the beginning because getting tested was really hard, and people had, lack of access to testing. And so some studies were done where it was a self-reported diagnosis of COVID, which is very nonspecific, and so that was really a critical thing. Yeah, go ahead.
I'll just add, just speaking to endpoints and designing these studies, I think more than once we said we're kind of, is it building the plane as we fly it, where we're learning about the disease as we go. And, at this point, in terms of outcome measures for studies, there are no validated surrogates for serious outcomes like hospitalization or death. So no validated virology surrogates, or even sort of softer clinical endpoints, symptom-based endpoints as a surrogate for hospitalizations and deaths. And in designing studies to look for benefit, to design one with an outcome of, or an endpoint of hospitalizations and deaths, requires a really, really large sample size, or restriction of the study population to those who are, most at risk for COVID progression. And then even then, so we have those risk factors that we've identified for COVID progression, for hospitalization, but there are still some who will go on to develop severe disease that don't meet those criteria. And there's still a lot that we're learning.
Yeah, I think another one of the challenges was, or it continues to be, that, people are diagnosed with COVID, they're told to stay home and to quarantine appropriately to avoid contact with other people, except for the people in their house. And so there's a real hesitancy for people to come out and go and be seen and enroll in a clinical trial. I mean, there are challenges for, if you don't have a way to get to a site, through private vehicle. I think many people appropriately are concerned about taking public transportation, or, how would they get there? And then also just the everything, at least initially, and in some places continues to be, pretty shut down. So the idea that you're going to venture out and go somewhere was a challenge, and really, I think, limited a lot of people from looking for opportunities to participate in studies. Mm-hmm. But a lot of progress has been made, and I think we're going to divide this conversation up into kind of two parts of what's been found to be effective and what we're still looking at. So maybe here we are a year later. You want to talk a little bit, start off with the progress that's been made with monoclonal antibodies, because it's been pretty significant.
Yeah, so that is what we have available to our outpatients with COVID-19. They're monoclonal antibodies targeting the SARS-CoV-2 spike protein. And there are several that have received emergency use authorization from the FDA. So really these agents are, these antibodies are still considered investigational at this moment. They don't have FDA approval. But there's been some level of evidence for benefit in terms of hospitalizations and deaths. And overall, so far, they look to be quite safe. So the very first antibody that became available was bamlanivimab. That was a single monoclonal antibody targeting an epitope on the receptor binding domain of the SARS-CoV-2 virus. And then following that, we got bamlanivimab, etesevimab, a combination monoclonal antibody of monoclonal antibodies, and then casirivimab, imdevimab, another combination. Now, one of the challenges is that these are given intravenously, and they're given over about an hour or so, and then they require an hour of monitoring. And so, but the good news is that they are available to some individuals. And we have phase 3 data now supporting the initial phase 2 data that led to the EUAs. And overall, for the most part, these monoclonal antibodies appear to confer about a 70% relative reduction in hospitalizations and deaths in higher risk individuals. But these studies are still generally small. The phase 3 study is obviously bigger, and we're seeing, in terms of the differences in hospitalization rates, something on the order of 6 to 7% in the placebo recipients versus 1 to 2% in the active treated. Another limitation to this is that the EUA monoclonals are limited to high risk individuals, and those are individuals who have risk factors for disease progression, and also do not currently meet criteria for hospitalization or have increased or new oxygen requirements. And so we don't have therapies for those who are not considered high risk. I just wanted to also just mention, just in terms of these monoclonals, so they all target different epitopes on the receptor binding domain of the spike protein. And so they're not all the same. Some target in terms of these and monoclonal antibodies that are coming. Some target the region that interacts directly with the ACE2 receptor, and others don't. And they also have different abilities to bind the spike protein depending on the conformation of the binding protein. I've learned a lot about these monoclonals over time. And so they also have different susceptibilities to these variants that we're now seeing, into mutations in the variants that might interfere with the binding of these monoclonals and their activity. And so with these variants then, Judy, maybe you can comment on the impact of these variants on the activity of the monoclonals that have an EUA.
Yeah, thanks, Kara. I think that this is the sort of Achilles heel of this approach. If you have a monoclonal antibody, it's directed towards one target, and you get mutations, and that target is part of that, then the agent won't work any longer, it'll be less effective. And so they're now, and that's why the combinations have gotten approvals, because they've shown that they have activity, and testing that's underway is really trying to evaluate their retention of this activity across these variants. So one of the things that's been learned about the monoclonals is they have to be used really early. I mean, the benefit is really best seen in those who receive treatment early. And some of the studies have required less than 5 days of symptoms. And so that requires people to be aware that there's a treatment that might be available, and to get tested and then to seek out that treatment. And I think that pathway is not, fully realized. And there's been a tremendous amount of effort to try to make these antibodies available, but it's not been as successful, I think, as people would like to see, and the full potential has not been realized because of the complexity of setting up places to do this. Some infusion centers have been converted for this, but I think, for the most part, that finding a place where people can safely receive this treatment has taken longer. And we, as a healthcare system, we're not set up for this. And so the treatment's made available at no cost to the patient, but the infrastructure for delivering it has to be organized. And I think some places have done an amazing job of figuring out how to do this, but it's certainly not equitably distributed around the country. And the fact that it has to be given early, I think, is also a big challenge. And there have been some studies looking at the monoclonal antibodies in the inpatient setting added to remdesivir, where it has not shown any additional benefit. So it's definitely an early treatment that requires early treatment. And the studies from Regeneron have looked at the presence of antibody at the time of treatment, and they were best able to demonstrate the antiviral effect in those who did not yet have antibody, but they still saw some clinical benefit even if people had developed antibody. So it's been I think we have learned a lot. We've also learned a little bit about, if it has to be given so early, well, what about giving it for prevention to people who have been exposed? And there's a recent study that came out this week about the high rate of household transmission. And is that an area to focus on for control of this kind of infection? Do you want to talk a little bit about the prevention studies?
Sure, yeah.
They just some of that information was in the press just yesterday.
Yeah, I mean, I think that the prevention studies, some of which are really more like early treatment studies, highlight the need or the benefit of giving these monoclonals early. And so there were a couple studies presented at CROI this year, just last month, for casirivimab and imdevimab, that combination, that was given in a household contacts study. And in that study, there were individuals who were both SARS-CoV-2 positive and negative at study entry. That's why I think I consider some of these more like early treatment. And they were given mAbs within 96 hours of the symptomatic household contact, first being positive on a SARS-CoV-2 test. And basically, none of those household contacts who got the active combination monoclonals developed symptomatic PCR positive infection, versus the number here, 3.6% amongst the placebo recipients. And also, for those that did develop infection, they had lower peak viral loads, and also a shorter duration of shedding, so a week compared to 3 to 4 weeks of shedding in the active treatment arm versus the placebo. So it seems there seems to be a true antiviral effect here, and given in this very early period after exposure, or with a positive SARS-CoV-2 test and infection, but without symptoms. And then similarly, at CROI, there were some data presented for bamlanivimab. There was a study where that was given in a long-term care facility, where there's a case of SARS-CoV-2, and that was given randomized compared to placebo to both the residents of the facility and also staff at the facility, and very similar findings were seen. Lower viral loads, they seem to clear the virus faster, and less development of symptomatic disease or progression of symptoms. So.
Yeah, I think one thing that we're hoping to learn from these studies is the relationship between the viral load early on, the change in viral load with treatment, and the risk for later disease progression, both in the short term and the long term. Because if we had this validated surrogate, and you could show that a treatment that reduced viral load by some number of days after symptom onset correlated really well with protecting people against more severe disease, then we could use that to evaluate drugs, and we wouldn't have to wait to see if the drug, led to hospitalization. And I know that there's a lot of work going on to try to figure out what that magic association is, but as it's been pointed out by many, this test of what we call viral load is a sampling of virus in the nasopharynx. It's not the same as measuring it in your blood. It's kind of got, there are some limitations to this measure, but it does appear that some of the early analyses of the data, at least in the Lilly publication in the New England Journal, suggested that there was a relationship between persistent viral load and the risk of hospitalization. So I hope that that's an area where that we can learn about faster ways to evaluate the effectiveness of drugs. And it is, the monoclonals are focused on the virus, but we also need to think about other types of treatment. But before we do that, the future of mAbs, where do you think we're going with these monoclonal antibodies?
Yeah, I think our experience so far has really made it clear that IV administered monoclonals are not scalable and easily implemented. So there are monoclonals in development that are under study with different routes of administration, easier to give, presumably, we think so, by intramuscular injection, subcutaneous injection, and even consideration of inhaled routes of administration. And so I think there's a lot we're learning about the pharmacokinetics of mAbs delivered by those routes, but there does seem to be a role for mAbs for therapeutics, but we need different routes of administration, and those are coming.
Yeah, and I think though, until we get them, it is really important for people to realize that this is a treatment that can be available in the outpatient setting. And there are some great resources for trying to locate this in different communities. And there's been a lot of effort to help expand the capacity. I think a lot of clinicians are kind of skeptical and feel like the evidence is not that strong. But I think there is some good evidence for high risk people. Yeah. And, it's not that we don't think they would work in people that are lower risk. It's just that for an emergency use authorization, the approval is made, based on a relatively small safety database in the setting of an emergency, to say that this treatment has more benefit than risk. And with some of the surges that are going on around the US and other parts, places in the world, I hope that there can be more utilization of this, this resource that's been made available.
Yeah, I agree, absolutely, and encouraging for those who do qualify, early treatment. So, and that does require rapid testing and easy access, but there are more and more options, it seems, to try to access the monoclonals. And in terms of the future, another thing I would consider, or that I think is important to be aware of, is that we see the impact of the variants. Judy pointed out the sort of narrowness of the monoclonals in terms of their targets. So the future does appear to potentially hold more combination therapies and combination monoclonals, and also monoclonals that target more conserved regions. So there's a monoclonal from Vir and GSK that was actually an antibody originally isolated from someone who had the original SARS-CoV, not SARS-CoV-2, and that antibody looks to target a conserved region across these SARS-CoV-viruses, and antibodies with those targets are likely to be less susceptible to variants, since mutations are less commonly arise in these conserved regions. So
yeah, I think we'll see more combinations coming and new routes of administration, but
yeah, so Judy, okay, so now we're fully aware that monoclonals are really available for high risk individuals. So what do we have for those who don't meet EUA criteria?
Yeah, so that's really the big hole here is that we don't have an oral or easily scalable, available agent for people who are lower risk. And I kind of put the candidates, and there are many, into some different buckets. There are antivirals that are, being evaluated that were developed for other RNA viruses. They're polymerase inhibitors. One developed by a pharmaceutical company called Ridgeback that started out with the name of EIDD2081, but now is MK4482, or Molnupiravir. It is an antiviral, and there was some data presented at CROI. So this is an investigational agent, so not something that's available on the, for other uses, but some interesting data that looked at ability of this virus to reduce basically infectious virus and positive virus culture in people who had early COVID-19, and they showed a very significant reduction by day 5 in infectious virus. So this compounds in completing phase 2 studies with Merck, and I think hopefully will continue to be evaluated as a possible antiviral. It's effective against influenza, I believe, and other viruses. Favipiravir is another agent not available to prescribe, but I think it is in Japan, but not in the US, which is also being tested as an oral antiviral, and phase 2 studies have been done, and there's some preliminary data. Look forward to seeing where that lands in terms of its effectiveness. There's also been work with Favipiravir for the hepatitis C drug. And I think on the whole, the data is not really that encouraging in terms of its antiviral effect, but most of that work has been done on hospitalized patients. And so it's possible that an agent that didn't look so good on hospitalized patients that's an antiviral might work better in early disease. There are protease inhibitors in development. There's Camostat, which is a drug that was approved for pancreatic fibrosis that may work on the serine protease. That's being studied in a study called Camelot, which is being done. And then it's also part of our Active 2 trial. So it's an oral agent, and look forward to seeing how that performs. And then there's a lot of other kinds of drugs. So these other host-directed therapies. I think some of the ones that we've heard the most about are Ivermectin and fluvoxamine. Ivermectin is an antiparasitic drug, and it's been used widely around the world as a possible treatment for COVID-19. I think more larger definitive trials are in the process of being conducted and organized. And I think we'll see once and for all whether that's effective. It's currently not recommended by the DHHS guidelines group. And then fluvoxamine, which was studied in a fully remote trial, which I think is another really exciting and interesting thing that's happened during COVID, are some very novel study designs. So this was studied in a setting where the participants never came to the site. They had the drug, they were basically enrolled over Zoom or by telephone, and the drug was sent to them, and they reported their symptoms. And so in a relatively small study, but it was a randomized placebo-controlled study. I think there were 80 in the fluvoxamine group and 70 in the placebo group. This was reported by Eric Lenz and his colleagues in JAMA. You showed some evidence of preventing clinical deterioration. And so larger studies with this agent are currently being conducted. So that's just a few. I don't know if there's others that you want to highlight amongst the myriad, or I guess I need to talk about one more, and that's convalescent plasma. From the very earliest time of COVID, there's been a real strong interest in the role of convalescent plasma obtained from people recovered from the infection. Initially, a large expanded access program in hospitalized patients, but also there's been interest in the evaluation of this in the outpatient setting. And because it likely as an antibody treatment, and it's multiple antibodies. I think the issue is it's hard to standardize what you're getting in convalescent plasma, and it's also been challenging to know what should be measured as showing that it's an effective unit. But regardless, studies are ongoing, placebo-controlled studies are ongoing in the outpatient setting, and look forward to seeing more rigorous data. I think there was one study from South America that showed some benefit in older patients, and then also in people who have B-cell defects. I think there's been really some of the most promising data there. But
yeah, I think for that study in South America, if I'm thinking of the same one, it was in older patients and also very, very early in their symptom course, within 72 hours of symptom onset, where there was potential benefit. I mean, kind of consistent with the monoclonal data as well for, very early use of antibody-based therapy.
Yeah, I think just recently heard about a study with budesonide, inhaled steroid, which is an interesting approach to treatment. And I think the study was not placebo controlled. I think it was open label, but did show some lack of progression in those who received this treatment. And again, I think that the timing issue here, there may be that drugs that have a direct antiviral effect need to be used early, but as you get a little further out, this is where some of the anti-inflammatory drugs before needing hospitalization, could be effective. And then the interferons. Do you want to say anything about interferons? That's another whole class that's being looked at, both lambda and beta interferon.
Yeah, I think that there was one study of lambda interferon that's been published that showed potential benefit in the outpatient setting, but still more evaluation needed. Another route that we're studying in active 2 is inhaled interferon. Interferon, I think we all know is potentially an effective antiviral, not SARS-CoV-2 targeted, but still early days for the interferon data. Yeah, and it comes with toxicities potentially, especially systemically given. So
yeah, I think if you're looking for, I think that's another key issue, is that we need drugs and studies that evaluate preventing progression of disease and hospitalization, but we also would like to show prevention or improvement in symptoms. And I think coming up with, rigorous assessment of symptoms and their resolution has been challenging to get a consensus of what's a symptom improvement and how long does it have to last before you say it improved.
Yes, I mean, as a new disease, we've been learning about what, even through our studies, what the most common symptoms are, and how severe they are across a study population. And it can be quite varied, although some are coming out as much more common, which you've probably seen in your own patients, which is like cough and fatigue, and GI symptoms being less common. But then how do we measure improvement? That's definitely a challenge, and there are different ways to measure it. And what the studies so far that have reported out have used has been time to sustained resolution, time to the first of a couple days where those symptoms are gone, of a list of targeted symptoms. And so what symptoms do we include in that list of targeted symptoms that we look for resolution or improvement in? And some studies have excluded mild cough or fatigue in that outcome. And so I think there's a lot that we are struggling with in terms of thinking about, if those symptoms are persistent, does that really mean, resolution of infection? Is that clinically significant still to the individual? So there's a lot we're learning as we go.
Absolutely. And I think one of the hardest things for clinicians is keeping up with the new information and it seems like every day a new study comes out or come out as a preprint, and there'll be a lot of excitement, and then it kind of disappears and it doesn't show up as a peer-reviewed publication. And I think we can all just be eternally grateful to the guidelines groups who are sifting through this information on a regular basis and really applying kind of rigorous set of criteria to evaluating, whether this should be considered something that can be recommended. And we have both the DHHS and the IDSA guidelines groups. And I think that we look to them to put all the results of these studies into context and to evaluate their, how much certainty we can take with the results, because it is really, really hard to keep up with this field.
Yeah, and I'll just add, these guidelines are constantly being updated frequently, and so I do turn to them myself frequently, and just because I don't think we've said it yet, right now the only endorsed treatments for outpatient COVID are the combination monoclonals. So from the NIH guidelines, the bamlanivimab, etesevimab, and the casirivimab and devimab combo, and from the IDSA guidelines, which were not as recently updated, the bamlanivimab, etesevimab combo. But those two are really the endorsed monoclonals that continue to retain activity against the most of the variants. So.
Yeah, and I want to make a comment. Thank you, Guido Silvestri, for your question in the Q&A about making the claim that these are not scalable. I mean, I think the point is they're difficult to scale, but it doesn't mean we shouldn't try. And as has been noted, 70% reduction in hospitalization in high-risk people. If we had taken that approach and said, antiretroviral therapy is not scalable, we're not going to try to give it to people, we wouldn't have made the progress we made. So I think it's a really good point that we should try to make them available as much as we can while we continue to look for easier to deliver therapies, and not just we're not saying throw in the towel. We're saying keep going, keep improving, and keep moving towards finding better things that can be made more widely available. So I do want to make sure that point is that I don't think either of us are saying we shouldn't try to scale them while we look for other treatments.
Oh, absolutely not. I mean, I think the phase 3 data have really, sort of supported the benefit of the MABs, and we need to make the community aware of the MABs, because I think one issue is that it may be that the most vulnerable, some of the most at risk are not even aware, and we need some way for our community, our scientific community, our community of healthcare providers to advocate for those individuals, and for them to advocate for themselves as well by being aware.
Yeah. And I think in terms of what we still need, obviously drugs for all stages of disease. We need drugs that we can use, that pregnant women can take. And I think this has been a real issue in the clinical trials that have been done with some of the early treatments. Pregnant women were excluded. Convalescent plasma was one of the only ones where pregnant women were allowed to be enrolled. Then we know that pregnancy is a time when the severity of COVID can be more intense and the outcomes can be impacted. So that's certainly an unmet need. And then also, obviously, drugs that work against these variants. So some of these other approaches, antivirals that aren't monoclonals, we don't expect the variants to have reduced susceptibility to them.
There's some questions about the role of remdesivir in the ambulatory setting. There are ongoing clinical trials enrolling, as I understand it, for remdesivir in this setting, given for, in one trial, given for 3 days IV. And so the longer duration as is given to hospitalized patients. But I'm not aware of any early readout of those studies. And so I am aware that there are some medical centers that are offering IV remdesivir in the outpatient setting, but potentially just to those that would otherwise meet hospitalization criteria. So sure, Judy, if you're aware of any other data.
Yeah, no, I'm not. I don't know. And then other formulations of remdesivir, I think maybe being studied, but I don't have any details on those. So yeah, maybe we can move to the questions now, looking through some of there's one question about combinations of approaches. And I think this is a really important thing. Certainly we have combinations of antibodies, but combinations of agents that work in different ways. First, we have to find things that work on their own and then put them together and see if they work together. So like an inhaled steroid with a monoclonal, or drugs that work through different mechanisms in high risk patients might also, well, even in low risk. So combinations, definitely, something for the future. There's also questions about vitamins. We didn't talk about vitamin D, zinc, vitamin C. I mean, these are all, there's been an incredible amount of interest in this. I think vitamin D deficiency is a marker of several, indications of health status, and studies linking low vitamin D to poor outcomes are, have been shown. Whether supplementing vitamin D will alter that outcome, I think still needs to be shown conclusively. I'm not aware of any data that makes that very clear, but I think there's a lot of interest in it.
Yeah, I think most of the clinical trials data has been in the hospitalized patient setting. And so I'm not so aware of data in the outpatient setting. And though I think a lot of individuals are being, these vitamins are being suggested to them. There is absolutely a recommendation to not give, for example, zinc beyond the recommended doses for COVID-19 prevention or treatment. And
then there's a question here about, the post-acute COVID symptoms and any sort of therapeutics for that. And I think one of the big questions, and hopefully the ACTIV-2 outpatient trial will be able to contribute to this, is whether receiving effective therapy early in the course of disease in any way mitigates or prevents or eliminates the development of long-term symptoms for COVID. So that's being looked at in the follow-up. We just don't have that many people who have, who are that far out to be able to report anything yet. But I think that's going to be a key finding as to whether, if you can treat early, you can basically prevent this from happening. But given the amount of people that have post-COVID symptoms right now, I'm not aware of therapeutic interventions that are being tested. Certainly a lot of interest in vaccination and whether that improves the post-COVID symptoms, but I don't know. Are you aware of anything?
I think that there are some studies in the pulmonary and cardiology realm looking at potentially, I believe, anticoagulation as well, just multimodal interventions for these long-term chronic symptoms.
Yeah. That's a big area I left out in terms of their other outpatient therapies are the treatments with anticoagulation, aspirin, and other agents that work through the coagulation system, because of many of the acute progression of COVID is associated with coagulation abnormalities. So there are the ACTIV-4B study is looking at apixaban, I think, and aspirin in outpatients to see whether it can prevent progression of disease. So those studies are underway, and we should hopefully have results from them soon, because that is a very scalable intervention that could be applied if shown to be effective.
Mm-hmm. And that ACTIV-4 study looking at I think also a cardiac and pulmonary outcome specifically. Comparing low and high dose, higher dose, more like prophylactic versus therapeutic dose of apixaban, and low dose aspirin versus placebo.
Okay, well, the other question about, there's a question here about subcutaneous injectable monoclonals. So there are the there is a subcutaneous monoclonal that's being evaluated. I believe Regeneron's evaluating their antibody in the subcutaneous delivery, and there's an antibody combination from Rockefeller BMS, so it's will be evaluated using the sub-Q route. And I don't know about scalability and overall, success particularly for sub-Q. I mean, I think sub-Q obviously will be easier than IV, but it will still require interaction with the healthcare provider of some sort. So that I think is yet to be seen, the significant advantage, but certainly will make it quicker to deliver, and it may expand the number of the types of locations where it can also be delivered.
Yeah, I think the other question is how much monitoring is needed, which adds to the time required for that interaction with the healthcare system. There have been a couple of questions about colchicine. That data are available only as a preprint, I believe. And so I think that that data certainly don't establish the benefits of colchicine, and more data are needed.
Yeah, I think it's a really interesting approach as an anti-inflammatory agent, and one that I think for short periods of time can be well tolerated, maybe even for longer periods of time, depending on the dose. But I think really need to wait for the published data to see more about the details of the study. It was stopped a little bit early, which was, I guess, because they felt the results were so promising. And so looking to see more information about that. But it certainly, I think it's an interesting approach.
There's a question about the use and controversies of using monoclonal antibodies after vaccination in vaccinated individuals. Well, there is theoretical concern that I suppose that having been vaccinated might I'm not sure actually interfere with monoclonal antibody activity, or that there may be less benefit perhaps, but I don't think any of that is known. And for those who do develop COVID and are at high risk, even after vaccination, the risk of severe COVID is reduced, but I think there may still be a role for monoclonals for the highest risk individuals. But
yeah, and I think it's the other way around too, is the question of if you get a monoclonal, how long should you wait to get vaccinated afterwards? I mean, hopefully we're not going to see a lot of vaccinated people getting COVID, but that's a hope. But so I think one of the questions has been, if you get COVID and you get treated with a monoclonal, how long do you wait to get a vaccine, especially if the monoclonal is hanging around in your system? Will it blunt your response to the vaccine or not? And I think there have been some recommendations to wait 90 days, but hoping to get some more information about that in a vaccine sub-study in the ACTIV-2 trial to try to learn about the vaccine responses after treatment with monoclonals. Somebody put a comment in the questions about post-COVID, just highlighting a small study that's looking at Ivabradine, which for this postural symptomatology, the POTS symptomatology, which sounds like it had some activity. I'm not familiar with that at all, but I think that is a component of post-COVID that is being evaluated, the orthostatic changes that are seen. Just looking through the other questions here, and well, here's a good one. Ethically, do we think it's that placebo-controlled trials in the high-risk outpatient population with mild to moderate COVID in the US are still acceptable given the data on the authorized mAbs reducing hospitalization and death?
Yeah, I mean, with that data, for those that are eligible for the MABs under the EUA, I think that it's not ethical to not offer the MABs through the EUA. And this has had a significant impact on, our thinkings around the design of clinical trials conducted here and outside the US. I think we're generally moving towards having an active comparator type designed trial instead of placebo-controlled trials for study populations that are eligible for the EUA.
Yeah, I think it has to be, people need to be made aware of the availability of the data for the effectiveness of the treatments. And it's much like, what was going on in the vaccine trials when effective vaccines were found. How do you continue placebo-controlled trials? And one of the arguments is that that the ability to continue to find other effective treatments is going to go faster with placebo-controlled trials, but participants need to be fully informed about the risks and the benefits. And the FDA has also made that point clear.
There's a question, is there any correlation between the use of monoclonals and the emergence of variants? So that's a great question. We don't have that data. I think there is certainly theoretical concern. The variants emerge under selective pressure, right? Either immune pressure and or one can imagine there could be selective pressure with a monoclonal antibody on board if there's ongoing viral replication. So we don't know the answer, but I think it's a theoretical risk and why it is likely in part that combination therapies that have a sort of higher barrier to resistance or the selection of mutations are really seem to provide an advantage.
Yeah, I think the limited information that I don't even know how much, if there's published information about what variants were seen in people who were treated with monoclonals, but I think that the continued replication of the virus in the population unchecked in many areas is really the main driver of the variants and not the therapies that have been given to relatively few people. But it's interesting. It's an interesting point.
So in an immunosuppressed individual that might have more ongoing replication and clear the virus less quickly, it's hard to. And it's in that circumstance that I think there's a lot of that the emergence of the variant has been postulated in those individuals that I can imagine that the monoclonal antibodies may, with a long tail, could potentially contribute, but something to study and to learn more about.
Yeah, absolutely. There's a question here about convalescent plasma and a comment of somebody who was talking about it, who made the point that if you were going to use convalescent plasma, it would make sense to use it from somebody who recovered from the same geographic region in the same time frame. In other words, to keep up with the changing virus, that you use plasma that's current and local. And I think that makes a lot of sense. And I know a lot of places, developed programs for recovered people recovered from COVID to be able to donate plasma for use. And as we, wait for the final results of some of the still ongoing randomized trials, I think it's a really interesting point.
I agree. I think the other thing is that the titer really seems to matter, at least from the available data in that RCT where there was benefit in the older individuals. They used a very high titer, over 1 to 1,000. And in another trial that was terminated early for lack of benefit. The titer used was like over 1 to 160. So titer dose might really have an impact as well.
Yeah. So we've covered a lot of territory here today, and I think, you know, I for those who joined hoping we would share some great secret about the treatment that we, you know, we're all looking for. I think we've identified more of the challenges than the answers, but I do think it is important to, you know, acknowledge the tremendous progress that has been made in this past year and the number of studies that are up and going and that are going to report out. And while we, you know, we need more therapies than what we have now, we do have some things that work in high-risk people, and finding ways to make those available, we need to continue to emphasize. And I think we need to do this to end the current pandemic and to be prepared for future. So the investment in this kind of work is, I think, still really important. But I'll let Kara make some closing comments. I just want to thank everybody for joining us here today, and also to let you know that Dr. Chu is going to be doing a webinar on treatment that's got data and slides, and that will be coming up. There'll be a slide at the end of this with that, but I encourage you to listen to her talk. I think it's on April 20th. But Kara, over to you.
Thanks. No, I really appreciate everyone's questions, and Judy, thanks for this conversation. I think we are definitely in a better place than we were a year ago, and I think that we will see more therapies coming, and it's been quite a collective global effort to deal with COVID. So thanks for your interest.
Yeah, and thanks for joining us today.
Yeah, April 20th for the webinar. And we'll go over some of the data we discussed today.
And thanks to everyone who's been working so hard on all of these studies. It's just enormous effort. All right, bye-bye.
Thank you.